My name is Dr. Obi Onyewu. I'm a native of Washington, D.C. Um, my parents were immigrants. I lived outside of the country for a while, but I came back for college and medical school. And I'm board certified, double board certified pain specialist. So today we're going to talk about, pain, which I think is pervasive in our society, and invariably it occurs as a natural process of aging and other factors, including injury. But it's something that we all can relate to. So, what is pain? So, the International Association for the Study of Pain defines pain as an unpleasant sensory and emotional experience associated with actual or potential tissue damage or described in terms of such damage. So essentially, if you have an injury, you have pain, you're going to experience it both physically and emotionally. So it's multifaceted. There's a process of how every individual interprets their own pain. No one's pain is the same. And it causes a lot of angst and anxiety among patients. So it's vital that, those of us who are physicians who treat it in a comprehensive manner and collaborate with other providers, to help get the patient to the right place. The problem, I think, is when I was in medical school, and it still goes on now, we don't learn enough about pain. We learn a lot about surgery, about disease processes, but actual pain and treating pain itself, they don't give us a lot of education about that. In many disciplines, pain education accounts for less than 1% of graduate medical education training in the United States. Only 1%, in spite of the millions and millions of people who experience pain for different reasons. So we break down pain in terms of an acute pain and what's a chronic pain. An acute pain could be an injury, could be from injury, could be from surgery. It's a new pain, and it serves as a warning that there's a threat to the body, potentially. Generally lasts for a short period of time and resolves when the threat is gone or when the person heals from a disease state. While chronic pain lasts greater than 6 months, can persist even after the injury or the illness has been treated and should resolve. But the 6 month period, I use the endpoint of what would be, considered acute. But in some spaces, they think about 3 months or 4 months. But certainly, if the pain persists after 6 months, it's considered chronic. What are the differences? The acute pain begins suddenly, often feels sharp, severe, and intense, caused by an injury or illness, tells us that something is wrong, lasts less than 3 months, resolves once the treatment is done. So if you have surgery, we expect the surgery to heal within a certain amount of time. The chronic pain may be constant or intermittent. It varies in intensity. It's not connected to any perceived threat or danger. It lasts greater than 3 months. The treatment requires addressing physical, mental, and social factors. I think about chronic pain like a burner. Acute pain, you turn on your burner, the fire comes on, you turn it off, it goes off. Chronic pain, you turn on the burner, the day you want to turn it off, it doesn't go off, the fire remains. And that's just an ongoing process. So chronic pain etiologies, arthritis, again, this is something that occurs for everybody. We age, we're going to get arthritis. Arthritis is wear and tear. It's just how we use our bodies, So, as a matter of fact, after the age of 18, we all start having arthritic changes. Usually, they're really, really mild. When, as we get older, they progress. People can have pain from strokes, cancer, nerve pain like from diabetes or shingles, back pain from arthritis in the back or disc disease like disc herniations, sickle cell disease, which is common in the African American community, gynecologic pain like endometriosis, fibroid tumors, and fibromyalgia, which is sort of a poorly understood widespread muscle and soft tissue related pain. What can cause it? Sports injuries, car accidents, traumatic falls, occupational injuries, In fact, things like nursing has a high rate of pain, truck drivers, prolonged illnesses, delays in seeking treatment. A lot of times, patients may have an arthritic joint, and they don't want to have the surgery, and they keep going and going and going until the joint is really destroyed. And they're just afraid of it. So they delay it and everything gets worse. Chronic illnesses, as I said, diabetes, vascular insufficiency, so circulation problems, some multiple sclerosis, Lyme disease can cause problems, rheumatoid arthritis, and just regular general osteoarthritis. And the difference between the two, one is an inflammatory disease state, and the other one is a progressive arthritic degeneration of a joint or multiple joints. So how do we evaluate? We look at when it started, the location of the pain, the chronicity, the duration, the frequency, how often does it occur, the character, is it an achy pain, a sharp pain, a burning pain, the severity, is it an 8 out of 10 pain, a 5 out of 10 pain? All of these things come into play in terms of how we evaluate the patient and what we're going to do. So we take a past medical history, we look at the surgical history, if the person's had surgery, is there progression from the surgery? The psychiatric history, their medication use, drug use. I think about smoking as a drug use, so there's a greater prevalence for back pain for people who are chronic smokers. Alcohol use, which can destroy your liver and can cause neuropathies. Your family history, there's some inherited disease states that are passed down through generations, and then your work history. So the first thing I always say is the patient is the expert on what's going on in their body. Nobody knows it better than the patient. So as providers, we need to learn to listen to the patient first. They give us the best information, the best clues on what's going on with them, and then we need to apply our expertise to what the patient tells us they're experiencing. A lot of times, and even with my own surviving parent, go to the doctor, they give my mom 2 seconds to tell her piece, and then they go on to say their piece. And I think, slow down, listen to the patient, hear what they have to say, and then go from there. So then we go through the physical examinations, cursory, look at, the motor strength, sensory to see if there are any issues with loss of sensation, the reflexes. All of these things tell us a little story to piece together about what the patient is going through, how they walk into the room, how they sit down, how they get up. You do a neurologic exam, you touch your patient, see where they're having their pain. Often if the person has more of a peripheral pain, you can, like a joint pain or soft tissue pain, you can touch it and you can see. A person says, well, it hurts in my shoulder. Well, it could be shoulder pain from a shoulder issue, but it could also be a nerve pain from a spine issue that sends more of an internal pain that you can't touch and reproduce. So those are these little teasing factors when I see and examine the patient that I look for. Then the diagnostic testing. We can look at x-rays, CAT scans, MRIs. The electrodiagnostic studies are nerve studies that we look at often to determine if someone has a neuropathy for something like diabetes, or if they have a radiculopathy, which is the medical term for a pinched nerve that can exist from the neck or from the lower back. We look at PET scans when we're looking for cancer-related pain issues, and then the laboratory testing. The labs can tell us about, diabetes, thyroid disease, liver issues that all can contribute to pain. A lot of times, patients complain of cold limbs and it's uncomfortable, and they may be anemic, and that may be it. They can complain of cold limbs, that could be a circulatory issue. So these are all things that we have to evaluate and determine. So then we talk about what do we do for treatment after we get to the point where we make our diagnosis. So I always tell patients, you have to keep moving. It's an interesting process, and pain makes us want to stay in one place, and it's the wrong process. You have to fight through that. And physical therapy, I hear a lot of patients tell me, well, the therapy made my pain worse. And I tell them, no, your pain was pretty bad. And, and you stop moving. And therapy is designed to help you move through that pain and to be functional. I like aquatic therapy because the water's protective. It's buoyant. There's a lot of resistance. You don't even have to know how to swim. Just walking in water is therapeutic. You find a place, don't be in a cold pool. No one likes that. You should make sure they have a warm pool. Occupational therapy looks at treating, upper extremity issues where they're functional things, like things to do with the shoulder, the arms, the wrists, elbows. Then we use over-the-counter medications, Tylenol, non-steroidal anti-inflammatories like ibuprofen. Even for those, you have to be very careful. There's a black box warning by the FDA for anti-inflammatories, and there are 3 issues that you have to worry about. They're great medications for arthritis, that's true, and generally safe, but sometimes with prolonged persistent use of ibuprofen, which is over-the-counter, people can suffer from cardiovascular events like strokes and heart attacks. And these are really, patients are more sensitive to these events if they have first-degree relatives who've had those kind of issues, like they have a mother or grandparent who had a stroke or who had a heart attack, and then they take an anti-inflammatory like ibuprofen daily. You have to be careful about that. The second issue is gastrointestinal. So these things can erode the lining of your stomach. So we always tell patients to take them with food. But even with that, you have to be careful. If you start feeling stomach discomfort, you have to stop taking it. I always use these medications intermittently, use them for a stretch, and then tell the patient to take a break from it. And the last is renal issues. As we age, the organs in our system that process every medication we take age with us. So our liver ages, our kidneys age, and they become less efficient at doing the work they do. The liver specifically works to metabolize or, break down the medications that we take and to use them effectively in our system. And our kidneys mostly excrete the medications after use. So they're very important, 2 very important organs that we have to be careful about. So when you're taking an anti-inflammatory, we need to make sure, especially as we get older, that we watch those numbers. Interestingly enough, even when you take a blood test to look at kidney function and it looks normal, when you're older, in medicine, there's a formula that we apply to adjust for age, to make sure it's telling us that the kidney is working appropriately. And I pride myself on being very thorough about these things in terms of the patients and caring about what I do. So I think every physician should be aware of this and discuss this with patients and make sure they do their due diligence whenever they're prescribing these kind of medications. Other things that we use, if you go to an emergency department for acute pain, they'll give you a muscle relaxant. Sometimes they'll give you a steroid. Steroids are like prednisone is a steroid. The steroids are really strong anti-inflammatories, and they're really good to use. The only problem is that with prolonged use or long-term use, there are other side effects that we'd like to avoid. Sometimes, they can cause osteoporosis, thinning out of the bone. They can cause, muscle atrophy. They can cause, and as we get older, sometimes they can cause, people to hallucinate or have psychosis. Sometimes they can precipitate diabetes. So we want to be careful, but they're very useful. They're very strong. They can knock out an inflammatory pain condition, quite efficiently. And then last but not least, the opioids, which we're going to get into a talk about that. I think a lot of people, there's a lot of news about it over the last several years, and a lot of people are worried about it, but my position as a pain doctor is not every condition that you're going to have that causes pain is going to be able to be treated with surgery or an intervention along those. Sometimes people have conditions that are going to be progressive, that don't have a cure, that need, something that's just a pure pain medication to help them get up every day and get through their days. The issue is, can we prescribe these medications and monitor them and, safely? So the World Health Organization put this together. It's sort of a paradigm of how to progress from mild pain using non-opioids and adjuvant therapies like physical therapy, ice and heat, along those lines, Tylenol, ibuprofen kind of medications. Then the mild to moderate pain, you use a weak opioid. A weak opioid is something like Tylenol with codeine, or tramadol. And then the same adjuvant therapies. Then you get to the moderate to severe pain where you get to the stronger opioids, things like a Percocet, a Vicodin, sometimes, and I'll talk about fentanyl really quickly. We use, in medicine, we prescribe fentanyl. We hear more about fentanyl as something that kills people. But if you go to a hospital for surgery, induction of anesthesia, post-surgical pain, we use fentanyl. The difference is this, and this is what the media never tells anyone. When doctors prescribe it, it's in micrograms. The stuff that's imported from China or comes across the border, that's on the streets, is in milligrams. It's 1,000, which means that it's 1,000 times stronger. That's why when this thing first came out and first responders would lay their hands on someone who used it or they touch something that's on it, it can be absorbed through the skin. In fact, when we prescribe it in a transdermal patch. So this fentanyl can be absorbed through the skin. But if you can imagine something 1,000 times stronger than what a doctor's prescribing, being absorbed, someone is going to almost immediately have an overdose. And I think they should make that distinction. When I talk to patients about this all the time, that even my cancer patients are worried about it. But this is about education and information and getting the right information and education across. And then for the severe, pain, interventional treatments could be surgery, it could be nerve blocks. Sometimes we do things, like implant pain pumps along those lines. So let's talk about opioid use in chronic pain. The first thing I talk about once I'm going to decide to use an opioid on a patient is, what we're going to use, what the problem is, what level of an opioid. Is it going to be a weak one or a stronger one? Educate the patient about the risk and benefits of use. The risks I talk about are addiction, because every opioid has the potential to be addicting. Patients tell me, well, I've never been addicted. And I say, yeah, it's not about you. It's the medication. You're fine, but the medication inherently has this quality, and that's why it's under the Controlled and Dangerous Substance Act, which is legislated by Congress. We have treatment contracts where we clearly outline what's expected from the patient. We do toxicology testing to make sure there's compliance with the medication use. We also use other medications, adjuvant medications. For patients who have really severe pain issues, we try to use a combination of different medications pharmaceutically. The opioid may be the strongest medication we use, but I think about medications as a lead singer and a backup singer. There's Gladys Knight and then the Pips. And it's true. And one of the reasons I tell patients this is because they say, this doesn't do so much for me. No, but it does. If a lead singer's on stage by themselves, they have to work harder. They have to project their voice further. When they have backup singers, it helps them out. And this is how we do medications. If you pair a higher risk medication with a lower risk medication so that the dosing of the high risk medication can be lower, then it works out well. We always start low and then we progress slowly with the patient and we see how they respond. My niece recently, she's a 14-year-old, my brother's daughter, she's 14 years old. She had an ACL injury. She played soccer. She's really good. They put a ringer on her, cut her down, she tore her ACL. So she had surgery, it's terrifying for her. So, been advising my brother and his wife about how to progress, the use for, the pain medication and everything. And now they're terrified about giving her pain medication. I said, go and watch the surgery on YouTube. They have everything on YouTube. If you watch the surgery acutely, you're going to say, you understand how much pain she's in. And then let's, be aggressive in the beginning and then back off of it as we go along. So we want to start low, and that's what I told them. See how she responds, and then if we have to make adjustments, we can make adjustments. You also want to clearly identify, what's causing the pain. A lot of patients come to me and say, "I have back pain." Okay, examine them, do X-rays, do MRIs, and everything's normal. And the answer to that is I'm not going to start an opioid for that. We're going to send you for physical therapy. We'll use an anti-inflammatory, maybe a muscle relaxer, do something more conservative, but we're not going to start a strong, potentially addicting medication for that. And then have a plan to taper. So if someone comes to you with acute pain, or if they have a treatable pain, chronic pain condition, let's understand and discuss with the patient that, yeah, we may have to, down the road, we're going to come off the medication, and this is how we're going to do it. So non-opioid treatment options, which I think are very important. We talked about the anti-inflammatories and Tylenol. Sometimes there's lidocaine patches. They have topical anti-inflammatories. There's something that's over the counter. It's called Voltaren gel. It's an anti-inflammatory, a topical anti-inflammatory. I love using that medication, and one of the reasons is whenever someone takes an ibuprofen or an Advil or Aleve, there's a systemic absorption in their system, so it goes throughout their bodies. When you do the topicals, it mainly stays in the area. If you use it for your shoulder, your knees, it mainly stays in that area. There may be a 3% absorption into your system versus when you use a pill, there's a 98% absorption. There are other medications that we use like gabapentin, Lyrica, and Cymbalta. They treat nerve-related pain. So if you have something like shingles, which is a secondary chickenpox infection when you get older and can be very, very, very painful. These are the kind of medications, diabetic neuropathy, these are the kind of medications we use. And then non-pharmaceutical adjuvants like back braces, knee braces. There's something called a TENS unit, which is a little unit that gives your soft tissue some electrical stimulation. If you've ever been to therapy, physical therapy, they have these things there too. I didn't mention ice and heat, which are really underrated modalities. No one likes having ice on them for some reason, but they don't. I tell patients, put the ice on and get a blanket. It's gonna be helpful. Yeah. I'll tell you, so I've had 4 knee surgeries. So one day my knee was killing me. I was working with a nurse, and the nurse said, "Why don't you put ice on it, Dr. Obi?" And I'm like, "Ice?" He said, "Yeah, put ice on it." So he's like, "All right, sit down. I'm going to wrap ice around your knee." So I wrapped the ice around my knee, and it helped. And I was thinking to myself, I should do this more often. Not just that, but I often say, listen to the advice you're going to give people. Do it for yourself. Yeah. So listen to the nurse. My mom is a retired nurse. The stories about that. That was my inspiration to get into medicine. So the other treatment options are minimally invasive. We do joint injections into the knees, the hips, the shoulders. The higher end interventions like image-guided or fluoroscopically guided epidural injections. A lot of people have heard about them. Sometimes we block nerves, sometimes we burn nerves. So there are nerves that we can get rid of in our system. So similarly to organs, we can get rid of our gallbladder, we'll be okay. We can get rid of our appendix, we'll be okay. Can't get rid of our brain or heart. We need to keep those ones. So there are things we can get rid of, and they're fine. I think about getting rid of a nerve that you don't need as, cutting off the gas supply to the burner in that analogy, to stop it from burning. And then there are higher end things like we implant pain pumps to patients. The pain pump is a tiny catheter that we put in the back, and then there's a reservoir that we put in the belly, and it just drips a pain medication into the spine. And just for the purpose of this discussion, to simplify it, the way pain works is that if you have a painful condition, it sends that information from the area. Let's say your knee hurts. The nerves from the knees send information to your spine and your spinal cord, and then from there, it sends information to a portion of your brain. And then that portion of your brain deciphers how you experience the pain. Is it an achy pain, a dull pain, a burning pain? The location of the pain, the intensity of the pain. And higher end pain management is, can we stop that information from getting there? So I would say this, if you have an arthritic knee and it caused you no pain, you would do nothing about it because the knee still moves the same way. The number one reason for joint replacement is when pain affects function because the knee's degenerate. So if we figured out a way to stop the pain in an arthritic knee, no one would have a joint replacement surgery. We haven't figured that out yet. So alternative and non-traditional options. I like this a lot because I don't think that we have a corner on all the information in modern Western medicine. So we don't do enough about with these options that are helpful, and insurances often don't pay for them. So acupuncture can be very useful when done the right way. There are pressure points in our system that can be affected when you put these really tiny needles there, and they release endorphins and they help us with the pain. Meditation. So after my first knee surgery, I was in physical therapy, and they have to bend your knee for range of motion. It was painful, and I wasn't ready for that. So, so the first time the guy bent my knee backwards, I screamed. And I was surprised at what came out of this 6'3", 215-pound man. I was like, that was me. And I was on a pain medication that didn't help, so I just stopped taking it. And so what I would do is, I think prayer is a form of meditation too. So instead, I would bury my head in the pillow because I was face down. I was on my stomach, and he was bending my knee backwards this way. And I would start saying a prayer, and I would start meditating, and it would calm me down. And in that, like sort of spirit, I was able to endure it. So I think, but there are formal ways of meditation, that you can actually learn, and there are things called mantras that you can say when you're meditating, but you have to practice medication in the same way that you have to practice yoga, which is also a process of how you can move your body through different positions, to actually, help your flexibility and heal yourself. Same thing with Tai Chi. Music therapy is a form of meditation too, to relax you. Massage therapy, which most insurances don't pay for, but everyone likes. I mean, they used to do it in physical therapy, but now they don't pay for it, they don't do it. But it's just like sort of treating the soft tissue of your system. Hypnotherapy is also a good. Again, we don't do it enough. Very similar to biofeedback. Biofeedback is a process where they hook you up to monitors, and they monitor sort of your body functions like the blood pressure and heart rate, and train you on how to control, sort of like the emotion of those factors elevating to try and bring them down. So it takes some time to usually do it in academic institutions. And the last one is medical cannabis, which is, sort of becoming common more recently. Now, I talk about cannabis, and a lot of times when I have patients, I think about 3 patients of mine who are in their 80s with severe arthritis in almost every joint, their spine, their hips, knees, everything. Not real candidates for surgery at their age, 83, 85, and 87. Can't really take opioids because of the side effects. Can't take the anti-inflammatories because of the side effects, and they don't do enough to help. And I suggested, medical cannabis, and the first response was like, Dr. Obi. Can't do that, because they're thinking, smoking a joint, and I'm like, no, it's not that. You don't have to smoke it. In fact, I'm not a proponent of smoking it. I mean, there are options you can use as a topical. You can take a tablet, so there are different ways to get it into your system. You can ingest it. There are droplets. You can ingest it into your coffee or your tea or your orange juice and drink it out, get into your system, and it has its effects. But it's no different now that we're seeing than any of these synthetic medications that pharmaceutical companies produce. I find it interesting that alcohol is legal in this country, and yet they make this hoopla about cannabis that they've now done a lot of research in, and they've made it into a tablet or gummies or edibles. They use it for cancer patients. And when people really press me on it, I'm like, calm down. we have a form of cannabis that they use to treat childhood epilepsy. So if they can do it for a child with epilepsy, why wouldn't we be able to do it in other forms for patients who have anxiety, patients who have cancer, who can't eat, patients who have pain or severe muscle spasms? So there are a lot of applications for it, and take the judgment out. The people who say, oh, no to cannabis, and then they go and drink. So the invasive treatment, surgery, general surgery, if you have an acute pain, it could be from, something like a gallbladder issue or appendix issue. The gynecological surgery, if you have endometriosis or fibroids, orthopedic and podiatry. So the number one thing that orthopedic doctors do, joint replacements for your knees and your hips. Then you have spinal surgeries, which encompass a whole variety of options. Other issues associated with chronic pain, anxiety. Invariably, anxiety and depression occurs if you have pain that changes your life. If you wake up in pain every single day, it's hard to be happy. Weight gain and obesity. I'm going to get into that separately. Insomnia. You have pain, you can't sleep. It cycles back to your depression and anxiety. Loss of employment. You have bills, you're stressed out. Loss of income, disability, which is a very, very difficult process to get through in this country. So there are a few things I want to talk about specifically that I like. One is this issue of the obesity and chronic pain. And one of the things that occurs when patients have chronic pain is they often gain weight. They gain weight because they become less active. They gain weight because they become depressed. They gain weight because they're up all hours of the night. They gain weight because they eat to feed that emotional, depression too. There are studies that have shown that their pain complaints increase with the increase in body mass index. Patients who have obesity have 4 times greater pain complaints compared to non-obese patients. And sometimes this also is associated with progression of the disease state. From the standpoint, our joints are designed to carry a certain amount of weight. When you have excessive weight all the time, then it's going to wear things down in your spine, in your hips, in your knees, and other places. 50% of women who have fibromyalgia were also noted to be obese. There are numerous studies that correlate obesity with the progression and severity of arthritis in knees and hips. So often, too, you see a rise in obesity seen frequently in our aging population, and some of that also is a natural progression. Men lose testosterone every decade as we get older, and women have changes in their estrogen levels. Testosterone is the lean body hormone, and estrogen isn't. So the reality is it's easier for women to gain weight and hold on to it than for men. So and this whole BMI index, I'm not so crazy about it. However, there's some merit to some of it, even though now contemporarily they're trying to change what we look at for body mass index, and they're looking more at abdominal girth to make the determination because it correlates more with cardiovascular disease and things that we worry about. Obesity also increases the complications noted after joint replacement surgery. And it also causes, patients to try and consume more opioids compared to non-opioids, and in non-obese patients. So what do? Concurrently treat the weight gain and the chronic pain. The challenge is it's difficult to perform high-impact aerobic exercises when you suffer from chronic pain. So we think about weight loss as in, can we burn it off? And the answer is when you have a chronic pain issue, no. If your back hurts, you're not going to run. If your knee hurts or your hip hurts, you're not going to run. You don't even feel like it. So, one answer is doing low-impact exercises, stretching, doing things in the pool, walking if you can walk, but dieting. This ultimately comes about calories, what you put in and how much you put in. The problem with diets is that there are a zillion diets, and some diets work best for some people and not so good for others. Depending on, what your genetic background is, what your race is, and things of that nature. There are food deserts all over the place, so not everyone can afford a really good diet. So I said low impact exercises, walking programs, aquatic therapy, eliminate processed sugars. We are a sugar-fied nation, and all sugar does, there are two things that sugar does related to pain. One, sugar is converted to fat in our systems, and two, all processed sugars are pro-inflammatories. So you drink something that's sugary, like a soda, a juice, you eat a pastry, and next day you feel sore, and you don't know. You think it's just a regular pain, but in your joints, it acts as an inflammatory agent. Water is the only zero-calorie drink. Now, I know it's hard to drink only water, but it is the only one. When they say diet this or diet zero that, I don't even buy it. I just say try and drink more water than anything. If possible, if you can get a nutritionist or a dietitian to help guide you through the process, that's another option. Sometimes diet doesn't work, it just doesn't. I mean, there are a lot of factors that work against dieting. One is motivation and the other is time. It takes a lot of time for people to get into a cycle of a diet or reduce calorie that's going to help them lose the weight. And then there are other complexities like genetics, gender, family dynamics, age, motivation, depression, and your socioeconomics. So then the other options are medical weight loss, which a lot of insurances do not pay for. And then the people who do it, they want you to pay out of pocket. In an aging population where your income doesn't grow as you age, for most people, it becomes stagnant. That's hard to do if you're on a fixed income. And then surgical weight loss, which insurances will pay for, but a lot of people don't want to have surgery. There are complications with it, and there's sort of an apprehension about having surgery too. So there are other options now. So for surgery, this is what they do for surgery. All paths lead to reducing what you put in your system. Every weight loss surgery option is designed to make your stomach smaller so you eat less. That's how it works. So now we're in the Ozempic and the Wegovy and the Zepbound. There are these medications that have become popular too. And I think these are good options. And the reason I say they're good options, although they've been vilified, the problem is that there are people who don't need weight loss for health reasons who use them for aesthetics. And that's the wrong reason. But the right reason is to use, for patients who need it, it's just, if you can tolerate it, to use these medications appropriately, because at a certain point, everyone needs help with it. There are intragastric weight loss balloon systems. And these are sort of clever options where they use an endoscope, just like you're having a scope where a gastroenterologist is looking down into your stomach. They put a balloon at the end of the scope, put it into your stomach, inflate it with saline, which is sterile water, and then take the scope out. Leave it in for 6 months, and it occupies about half your stomach. And it makes you feel full sooner. So invariably, it makes you take in less calories. And then 6 months later, they take it out. There are some systems where they don't have to go back in to take it out, where it naturally degrades because it's sterile water and it doesn't matter, and you excrete it, through a bowel movement. It's just like a little sliver of a greater balloon. There's a swallowable pill balloon system too that's newer as well, where they put a capsule in and it can expand in your abdomen, and that degrades on its own. Sometimes they put a capsule in with a tiny catheter, and then they inflate it with either saline or nitrogen oxide, and then take it out. So who can't get this kind of option? If you had previous gastric surgery, you don't want to mess with it. If you have an inflammatory bowel disease, the same thing. A large hiatal hernia or gastric mass, or if you're prone to bleeding. So I'm going to summarize. Our long-term goals of treatment: treat the person first. Everyone is different. Understand that. It's not a one-way-fits-all process. Tailor your treatment to the individual. Listen to your patients, understand where they're coming from, be empathetic. Your goal is to reduce and control their pain. I always tell patients, not pain elimination, it's pain management. There's a certain amount of pain that we all can afford to live with. When it crosses a certain threshold, then you see a specialist like myself. But if it doesn't, people are going, if you get it beyond, back down to something that's manageable, people are going to be happy with that. Treat insomnia because, it's a cycle. If people are awake all the time, they're experiencing more pain per hour, and then they require more medications, and then insomnia is associated with a host of other medical problems. Treat the associated behavioral health issues, like anxiety and depression. You want to treat, advise the patient about nutrition, wellness, weight management, lifestyle changes. Stop smoking, for instance, if you're a smoker. If you're a drinker, stop drinking. If you love sugary food or sugary drinks, make that adjustment. Provide a home stretching and low impact exercise program and encourage the patient to do it. I wake up every day and I stretch, and that should be, sort of a habit, a lifestyle change that anyone can do it. It's not that difficult. You just have to commit to it. And that's my talk, folks. All right, any questions? Yes.
Is cannabis, I've never tried it, tipped it.
And don't be embarrassed about that. So I'm going to, one disclosure too. Prior to it being legalized and for adult use, which is recreational use, which I'm not crazy about because of kids, I'm the last chairperson of the Maryland Medical Cannabis Commission. So I've done a lot of reading and research about cannabis use for medical purposes, and I'm a proponent of it. Yes.
Would you say it's comparable to aspirin in terms of its benefits and adverse, whatever?
No, I mean, I wouldn't say it's comparable to aspirin because I think for those of us who treat chronic pain, people often say when their pain is not controlled, oh, that's like taking an aspirin. so
aspirin is also comes from an herb, right? And now we just take it. I mean,
Yeah.
anybody can take it anytime. So it seems to me like a mild gummy, a cannabis gummy, might be a comparable impact on your body.
So this is what I would say. I think everyone is different, and every medication that you have has its own host of issues. Anytime you see a medication on television, they always list at the very bottom, they rattle it off with a gazillion side effects and everything of that nature. And that's true because everything has a side effect. Even cannabis has its own side effects and everything. So you have to be careful with it. It's still a medication. I wouldn't put it in the category of sort of like a Percocet or oxycodone or morphine from that standpoint. But I wouldn't say as benign as aspirin either. But I do think that there are over 100 different species of cannabis plants that we cultivate here in the United States and produce into a medication. So I think it's about finding what your fit is, what works for your system, and I think in the right scenario, it can be safe. There are other issues with cannabis, true, that can be, harmful, but that's like every other medication. It's like taking a Tylenol. If you take excessive Tylenol, it can ruin your liver. You take excessive ibuprofen, it can cause problems in your stomach, it can cause problems in your kidneys. So I think, no matter what it is, there's a process of, being careful with and respecting every medication that we use. Yes.
I try to not be naive, and I know there's a lot of stuff that comes on the TV. But there's a new medication, and it has 3 letters, and the second and the third is EV. And it's been, they're talking about it a lot. It's just been approved to be available in Maryland. And it's a pain reliever, and it's supposed to be non-addictive, but extremely effective with regard to usage. Are you familiar with this new thing? I mean, it won all this money on the shark, not the guest.
No.
I forgot, I'm stupid saying that.
No, not at all. No.
But the point I'm trying to say is that this is very well touted.
Correct.
In Maryland.
So what I would say is, I'd have to have the whole name of it to be honest with you, but what I'll say is that this is the progression now, in this age where we are all trying to get away from opioids, to get into a medication that is non-addicting, that's safer, and that's going to be the trend. The pharmaceutical that produces that medication is, they'll have a windfall. I would say this, the evolution of medicine is always looking for something better. A few years back, we didn't have a cure for hepatitis C. Now we do. So, whenever there's a need, there's an innovation. If you can get the name, you can get it to Bernice, I will be more than happy to research it and get back to you personally. I don't mind that at all. I'm always in search for new options that will help patients. Yes.
Well, I have some pain, it's not in my joint. I don't know, how do you know if it's like neurological or if it's muscular?
So I would say this. My first approach would be, to hear where the pain is and how you experience the pain. And then the next is to examine you and then determine whether we need to get, more studies to determine scans or blood work, things of that nature to make a determination. And then, if the patients who come to my clinic, they think a lot of times people complain about waiting, but, my process is I want to get it right. If it takes more time to get it right, our system isn't designed for physicians to spend more time with patients, even though it should. I once saw a cancer patient, and she'd waited, and I'm embarrassed to say this, but I will say, she waited about almost 2 hours to see me. And then when I got into the room, I apologized, for the wait. And I asked her, so what brings you here? And she said, Dr. Obi, before we start, I want to ask you one question. And she's around my mother's age. She said, would you make your mother wait this late? I took a deep breath, gathered myself, said a mini prayer, looked for inspiration, and it came to me.
You hear cards?
Not cards yet, but I'll make sure I get cards. I'll get cards to Dr. Smith or Bernice. And I told her, I said, if my mother came here and had to wait this long for me, I would do my best to make it worth her while. And that's my promise. That's what I do. So in terms of evaluating your pain, that's what it would take. The other thing I think is an educated patient is the best patient. So, really trying to break down to the patient what is causing their pain and what we're going to do to treat the pain becomes important to me. I've been in practice for 21 years. 13 of the 21 years I spent in academia where I used to do research, practice, and teach other doctors pain medicine. So even though I'm in private practice now, my approach is still the same. I still believe that understanding, in as simplistic a manner as possible, why you're having the pain, what causes it, and how we're going to treat it. Even if it's saying, hey, look at this x-ray. This is what a normal x-ray looks like. This is what your x-ray looks like. And that becomes crystal clear. Or an MRI. You don't have to be sort of super scientific to look at normal and look at abnormal and be like, oh, crap, that looks bad. So that's what I would do. A lot of times, you're not going to have joint pain. It may be in a muscle, it may be something else, it may be a nerve. And we have to, determine what it is and then discuss what the best treatment options are.
Where are you located?
Good question. So in my clinic, we have about 10 clinic locations in Maryland and Delaware. 2 in Delaware, 8 in Maryland. But I only go to 2 of the locations because I'm only one person. I wish I could go to more, but we have an office in Gaithersburg and Olney. We have offices in Heights off in New Hampshire Avenue, not, it's a drive down the road, and one in Lanham, I'm in Lanham, and 4 in Baltimore, and then 2 in Delaware. So in Delaware, I go to Delaware because we acquired a practice there. I had a really dear friend of mine who taught me a lot about being a doctor and was just a wonderful individual who unfortunately, succumbed to a rare neurological disease, and they were having problems in the practice. So as a favor, he took over the practice to keep it running, and at the time to ensure that he would still have health insurance for his treatments. And then he passed away last year, and it was hard to find a physician who wanted to live in Delaware, believe it or not. So I drive there once a week to have a physician presence there and to honor him. So honestly, he was just a wonderful person to me, and there was almost nothing I wouldn't do for him. So it's a 2-hour drive, but it's a labor of love. I tell you. All right. Yes.
Is the medical cannabis equivalent to the street cannabis in that if you had a job and you were urine tested, it would come up positive?
Okay. So, yes. The simple answer is yes. The more complicated answer is no, because you don't know what you're getting on the street. In Maryland, the dispensaries are sanctioned. They have rules for how they cultivate the cannabis and how they process it and what gets into a state-sanctioned dispensary. In the Obama era, they made a rule that said if the state voted to allow, cannabis for medical use, they would not, prosecute any physician or patient using it. So, we always require the patients, even though, you can get it now because it's legal for adult use, we require patients to have a medical card. The other benefit of the medical card is that if there are lines in the dispensary, you can get ahead of the line. And some of the products for medical use are separated from the products for adult recreational use. So if you work for the federal government, you're out of luck. They're not going to, it's still on the federal statute, it's still illegal, but in the states, you'll be okay. And because it's legal for adult use, if you have a state job, they can't really do anything. But I always recommend, have your provider, just write a note and saying, yeah, she's using it for medical use.
So you can drive if you're on that?
Good question. Yeah, there are a lot of medications that they tell you not to drive or operate equipment with heavy equipment. That's the usual term that we use and everything. But you can have a side effect from you can have a side effect from blood pressure medication, from diabetes medication. So this is about judgment, driving. It's going to be hard to tell someone in absolute terms not to drive, especially if they don't have any side effect to the medication, whether it's, cannabis or anything else. Not all cannabis is neuroexcitatory. Not all cannabis makes you feel euphoria or feel sedated or high. Just to simplify it, there's a THC version, which is the portion that people can get high off of, and they manipulate it when they're producing it for medical use to help with sleep or to help with anxiety. And there is a CBD version that is used almost exclusively for medical use. That's the portion that they use for children who have seizures and, for other things. So that portion shouldn't make you feel high or anything of that nature. So the answer to that process is judgment. It is judgment with every medication we have. Any other questions?
Okay, there are no other questions. Thank you, Doctor.